acne, and erythroderma. And within this presentation, there's going to be a few scenarios and questions that can be answered by the polls, just to make it a bit more interactive. And if you have any questions throughout, feel free to put it into the chat box. So let's begin with psoriasis. There's 5 main types. So there's guttate, plaque, erythrodermic, pustular, and inverse. So it's a non-contagious, common chronic papular squamous disorder, and it's characterized by well-demarcated scaly plaques and a relapsing remitting course. And basically the area is typically red, dry, itchy, and scaly. It's more common in Caucasians, and it can occur at any age, but normally there's 2 peaks. So there's one at 20 to 30 and one at 50 to 60 years old. And it can vary in severity. So that means it can be from small localized patches to complete body coverage. And the cause itself is unpredictable. So we have a question here. Psoriasis is most likely to be worsened by which one of the following? A, opioids, B, interferon alpha, C, cyclosporin, or D, beta blockers. I'll give it maybe 10 more seconds. Okay, great. Yeah, the majority of you guys got it right. It's D. So other medications that can kind of aggravate or exacerbate psoriasis can be calcium channel blockers, lithium, antimalarials, NSAIDs, terbinafine, TNF inhibitors, and withdrawal of systemic steroids. Now, other risk factors can be genetics, because psoriasis has a strong genetic component, and most of the identified genes are related to MHC and T cells. Another risk factor can be immunological. So it's shown that there's abnormal T cell activity that stimulates the keratinocyte proliferation. And then injury to the skin can also skin changes at that point, and that's known as Keebler phenomenon. And hormones have been known to kind of change the severity in the disease. So for instance, it gets worse during puberty, menopause, and postpartum period. However, during pregnancy, most patients do feel like there's an improvement. In HIV patients, it's known that psoriasis can be quite severe. Medications that we've gone through on the right-hand side, and lifestyle changes, lifestyle factors. So for instance, consumption of alcohol, if there's skin dryness, usage of hot water in the baths or showers, as well as smoking. And then the last risk factor would be microbes. So it's known that streptococcal throat infection can cause or precipitate guttate psoriasis. And other microbes such as Candida albicans and Staph aureus can worsen the disease. So another SBA is, what percentage of those affected with psoriasis experience nail changes? A, 15%, B, 25%, or C, 50%, or D, 90%. Oh, I accidentally showed. Okay, I accidentally showed the answer, but yeah, so it was C, which was 50%. So the nail changes that you'll see in psoriasis is hyperkeratosis, nail pitting, onculosis, and splinter hemorrhages. You will also see leukonychia, which is basically where you see like white spots or ridges on the nail, as well as thickening and loss of the nail. Now, these can affect both the fingers and the toes, and they don't really reflect the severity of psoriasis. So the first type that we're going to look at is plaque. And chronic plaque psoriasis is the most common subtype, and it's seen in 90% of the patients. So it's seen as raised, inflamed areas, and it's covered with silvery, white, scaly skin. It's symmetrically distributed, and it can be quite itchy for the patient. And in darker skin colors, it can look as if it's a white appearance, a grayish scale. It's commonly found on the elbows, knees, scalp, and the back, as well as the trunk and the gluteal cleft. And this itself can also become fissured and painful over joint lines, so on the palms of the hand or the soles of the feet. If you remove the scale, it can cause pinpoint bleeding, which is called Auspitz sign, which is seen in the picture below. So again, we have another question. Which type of psoriasis is most likely to occur following a streptococcal infection? Yeah, I can see in the chat, I think. Oh, no, yeah. I think the poll should be up right now. Sorry for the delay. I'll give it a bit 10 more seconds. Yeah, most of you guys got it right. It's A. So this is most common in children and adolescents. And what you'll see is basically teardrop lesions, and it's mostly seen on the trunk and the limbs, and the distribution is normally symmetrical. The treatment is that most cases normally resolve spontaneously. However, a third of them will develop into classic plaque psoriasis. So the treatment would be around like mild, moderate steroids, coal tar, ultraviolet B phototherapy. And in this case, it could be tonsillectomy if there's recurrent episodes. The next type we're going to talk about is pustular psoriasis. And this can be subdivided into generalized, which includes acute and localized. So in acute, it rapidly develops, and there's normally erythema and pustules, and it's a derm emergency. So the patients may feel unwell with fever, malaise, and arthralgia. The other type is localized, which is normally called as palmoplantar, and you will see pustules and plaques, and it's normally associated with smoking. The next two types is inverse. So this is seen in points where the skin will touch rub together. So these are sites like axilla, the groin, genital areas, or the inflammatory folds as seen in the picture below. And then erythrodermic. So we're going to talk about erythroderma in more depth because it's the third condition. But as we briefly touch over it here in psoriasis, it's a rare condition, and it's a widespread inflammation, and it's widespread inflammation of the skin, and it basically covers most of the body surfaces, so around 75 to 90%. And it is life-threatening, so you'd have to do hospitalization, check the IV fluids and temperature regulation and supportive care. But then again, the treatment, we're going to go into a bit more depth later on. So before we go into the treatment of psoriasis, we need to know that corticosteroids are basically classified depending on their potency. So it's classified based on mild, moderate, potent, and very potent. And there's a helpful mnemonic just to remember the drug names, which is help every budding dermatologist. So for mild, it's hydrocortisone. For moderate, it's Umovate. For potent, it's Betnovate, and for very potent, it's Dermovate. And as a rule of thumb, you should aim for a 4-week break before starting another course of topical corticosteroids. Other side effects of corticosteroids can be skin atrophy and striae. And very potent corticosteroids, they're not used in primary care, so they can only be prescribed by the dermatologist, and you can only use that no longer than 4 weeks at a time. So the treatment. So normally you can always use emollients in all types of psoriasis, and they are basically moisturizing treatments such as mineral oils and petroleum, and they can be applied directly to the skin in order to reduce water loss. But normally the first line of treatment is topical treatment. So you normally give potent corticosteroids and vitamin D analogues, which should be applied once daily separately for a month. And if there's no improvements after 8 weeks, then the second line is to just purely use vitamin D analog twice daily. Now, if that is still ineffective, then you can use potent corticosteroids for up to a month, or you can use coal tar preparation applied once or twice, or short-acting diphenol. Now, the way that coal tar and diphenol work is that they inhibit the DNA synthesis, and diphenol, you'd have to wash it off after 30 minutes, and it does have adverse side effects. So it can cause burning and staining, so that's why it's normally third line. And vitamin D analogues, they basically reduce your epidermal proliferation. So if topical treatment doesn't work, then there's second line management, and that would include phototherapy. So phototherapy can include broad or narrow band ultraviolet B, but normally the preferred choice is band. An alternative can also be photochemotherapy, such as PUVA. So which one of the following complications is most associated with PUVA therapy? A, squamous cell cancer, B, malignant melanoma, or C, dermoid cysts? Oh. Well, I don't know if I can see. Okay, so it's A, which is squamous cell carcinoma. And the other adverse effects can also be skin aging. So the way that phototherapy works is that it slows down the excess growth of skin cells, which reduces plaque formation. It also limits the growth of skin cells by affecting the DNA. Also in second line management is systemic non-biological agents such as methotrexate. However, you'd have to monitor the liver function tests as it can cause hepatotoxicity. Another drug that can be used is cyclosporin, and this can be used in first line if, for instance, if the patient's got psoriasis flares, or you need to do short-term control, or if the person has got palmoplantar psoriasis. And the side effects for cyclosporin can be remembered using the 5 H's, which is hypertrophy of the gums, hypertrichosis, hypertension, hyperkalemia, and hyperglycemia. And because of the side effects, you'd have to monitor the blood pressure, the fasting glucose, as well as UNE levels. And the last drug is acitretin, which is teratogenic, so you can't use it in pregnant women, and hepatotoxicity. So if second line management doesn't work, then there's also third line therapy, which is systemic biological therapy, including tumor necrosis factor antagonists, such as infliximab. So as an overview, normally you use topical treatment. If that doesn't work, second line management includes phototherapy and non-biological agents like methotrexate and cyclosporin. If that's still ineffective, then you can use drugs such as infliximab. So here in scalp psoriasis, again, you're still using potent corticosteroids for a month. And if there's still no improvement, then what you do is that you use a different formulation. So for instance, like shampoo or a mousse. Or you can also use a topical agent before applying the corticosteroid. And then for inverse, the difference is that you're still using corticosteroids of mild or moderate potency. However, you can only apply it for a maximum of 2 weeks. And that's because the areas are quite vulnerable to steroid atrophy, so you can only use it for a shorter amount of time. Second line treatment for this type would be vitamin D analogues or tacrolimus ointment. So we're going to talk a bit about vitamin D analogues. So the way that they work is decreasing your cell division and proliferation, and it reduces the scaly and thickness of the plaques, but not the erythema. And the advantage is long-term use, unlike corticosteroids, and they don't smell or stain, unlike coltan diphenol. However, they are avoided during pregnancy. The complications is that in psoriasis, there's increased incidence of cardiovascular disease, venous thromboembolism, or Crohn's disease. It can also cause psychological distress and metabolic syndrome. And then psoriatic arthritis is seen in 10% of the patients, and this is basically a joint disease, and it can occur before the skin manifestations. And in 90% of patients who have psoriasis and psoriatic arthritis, you will see the nail changes that we've talked about before. So now we're going to move on to acne vulgaris. And it's a common chronic skin disorder, and it normally is seen in 80 to 90% of teenagers. And adolescents, it's mostly common in males more than females, but then in adulthood, it's the opposite. So you see it more commonly in women. And acne is basically the inflammatory disorder affecting the pilosebaceous unit. So this includes the hair follicle, the hair shaft, erector pili muscle, as well as the sebaceous glands that produces skin oils and sebum. And it's thought that the blockage and inflammation of these units will lead to acne vulgaris. The acne itself can be divided into non-inflammatory and inflammatory. Non-inflammatory is comedones, and this is basically dilated sebaceous follicles in the skin, which is known as pores. And they can either be open, which is a blackhead, or closed, a whitehead, and this is due to the accumulation of bacterial and cellular debris. Then in inflammatory, it consists of either papules, pustules, nodules, and cysts. So in papules, as you can see in the picture, it's a solid raised lesion and it's less than 0.5 centimeters in diameter. In pustules, it's the same as papules, it's just the fact that it contains pus. Then in nodules, it's a solid raised lesion with a deeper component. And in cysts, it's a thin walled closed capsule or a sac containing fluid, and it's quite painful for the patient. So the pathophysiology is that the cause is multifactorial. So there are normally four main factors that contribute to acne vulgaris. The first one is overproduction of keratin. So that can cause keratin plugs that may block the hair follicle itself. 2 is excess production. So androgen hormones are known to kind of increase the production of sebum, and that's why acne is exacerbated by puberty, and it can be improved with anti-androgenic hormonal contraception. However, patients with acne normally have average levels of androgens. 3rd is P. acnes, and basically it's a gram-positive bacteria that is seen in the skin's natural flora. And 4 is inflammation. So what happens is that with the keratin plugs and sebum, which is basically accumulating in the hair follicle, it can cause comedones like we've talked about before. So open comedone is blackheads, and this is when there's a dilated sebaceous follicle, and it's given the name because basically the melanin is oxidized into the air, giving the appearance of a blackhead. Whereas closed comedone is when the follicle is sealed up, known as whiteheads, and these are basically kind of called as the precursor of inflammatory acne. And this is because once the follicle is blocked, it causes a closed environment, and so that means that the P. acnes in the natural skin flora feeds on the sebum and can cause bacterial overgrowth. And then this can attract immune cells and results in white pus with inflammation known as pimples. And then because of follicular rupture, it can lead to inflammation and result in papules, pustules, and nodules. So the risk factors is hyperkeratosis can run in family. Patients with polycystic ovarian syndrome, because of the fact that they have increased estrogen levels, and there's increased sebum production. It can also be due to psychological stress. So because stress increases cortical release, it stimulates sebum production. And there's also drug-induced acne, such as phenytoin, corticosteroids, and lithium. Excessive face washing can irritate the skin, as well as moisturizers and cosmetics, because it can block the pores. The most common sites are face, neck, and the back because of the abundance of sebaceous glands within that area. Now, scarring. This is a complication of acne and it's normally seen in the severe type. So you have ice pick scars, which are deep, narrow pitted scars, as you can see in the picture below. There's also rolling scars, which are broadened depressions with a sloping edge. Boxcar scars, which are again broad depression, but they have sharply defined edges. And hypertrophic, which are thick, lumpy scars. And the way that they can be treated is through a range of options, such as dermabrasion, laser resurfacing, as well as skin needling. However, it is known that hypertrophic scars, the last one, is known to still recur after successful treatment. So we have another scenario. A 15-year-old teenager has presented with signs of acne on his forehead and cheeks. Following examination, the GP concludes the teenager does have evidence of mild acne vulgaris. Which of the following skin changes has the GP most likely identified in order to reach his conclusion? A, macules, B, papules, or C, comedones? I think some people have their mic on, so if you can mute yourself, that would be great. Okay, I think the poll should be up. I'll give it 5 more seconds. Okay, yeah, the majority of you guys got it right. It's comedones. So the way that acne can kind of be classified is based on the severity, mild, moderate, and severe. And in mild, you only see comedones with basically a few inflammatory lesions. So as you can see here in the picture, she doesn't have a lot of inflammatory lesions. It's just a few either blackheads or whiteheads in the picture. And in moderate, there's normally widespread non-inflammatory lesions with numerous papules and pustules. And then in severe, there's extensive inflammatory lesions, and this can include pitting, scarring, and nodules. So the management, you'd have to do skincare advice. So you'd have to tell them not to use non-alkaline synthetic detergent cleansing products twice daily. Avoid any oil-based products, remove your makeup at the end of the day, and advise to not pick or scratch the lesions as it can increase the risk of scarring. You can also give support for associated mental health disorders and advise the patient that it may take several weeks in order to see the effects. So here we have another scenario. A 13-year-old has presented to a GP complaining of having too many spots. On examination, she has a mix of open and closed comedones on her face. What is the first line management of her mild acne? A, topical benzyl peroxide with clindamycin, B, conservative, C, topical hydrocortisone, or D, topical benzyl peroxide. I'll give it 5 more seconds. Okay, so it is D, benzyl peroxide. And the reason that this is because in mild acne, the first line treatment is single topical treatment. So it can either be with retinoids or topical benzyl peroxide, as we've seen in the question below. In the previous question. So in retinoids, the way that they work is that they have anti-inflammatory effects and it can reduce the comedone formation combination. With benzyl peroxide, it does have antibacterial effects, and it can reduce inflammation as well as unblocking the pores. Now, just to bear in mind that topical retinoids are contraindicated in pregnancy, so you have to avoid that with pregnant women at all costs. So if single topical treatment doesn't work, then you can use a topical combination therapy. So that can be antibiotics with either retinoids or benzyl peroxide. And on the picture on the right-hand side is a useful way to kind of just show the different combinations that can be done for mild, moderate, and severe. Now, for moderate to severe acne, the first line of treatment is topical combination therapy. So that can be from any of the options on the picture on the right-hand side. So in moderate to severe, it's topical combination. In mild acne, first line treatment is single topical treatment. Now, if topical combination therapy, you normally use it for 12 weeks. And if this still doesn't work, then you can add in oral antibiotics alongside topical treatment. So the first line normally used is limecycline, doxycycline, or erythromycin. So limecycline, you cannot use it in children under 12 years of age, or those who are pregnant or breastfeeding. So in pregnant women, the alternative would be to use erythromycin. So then you'd use the oral antibiotics with topical treatment for 12 weeks. Now, oral contraceptives, they can be an alternative to oral antibiotics in women, and they should be used in combination with topical agents. So Diana is the most effective oral contraceptive pill because it has anti-androgen effects. However, it does increase the risk of thromboembolism. So that means that's why it's second-line treatment, and you can only use it for a short amount of time, 3 months, and women should be counseled about the risks. So again, the treatment. So basically, first-line treatment is always topical, and secondary care management is indicated if either mild acne hasn't responded to two completed courses of treatment. So that means either the single topical treatment for 12 weeks, and then the combination therapy for 12 weeks, or if moderate to severe acne has not responded to previous treatment, that includes an oral antibiotic. Or secondary care management can also include severe acne with scarring or pigmentary changes, or those that are contributing to persistent psychological distress or mental health disorders. So for secondary care management, you normally prescribe oral isotretinoin, which is effective for a last line treatment and can only be prescribed by a specialist. So here we have another scenario. A 12-year-old female presents to the dermatologist as a severe acne has not responded to any topical therapy or oral antibiotics. The dermatologist has decided it is appropriate to start treatment with isotretinoin, a systemic retinoid. Which one of the following side effects should the patient be counseled prior to starting isotretinoin? Give it maybe a few more seconds. Yeah, the majority of you guys got it right. So it was A. So yeah, you're not supposed to give it to pregnant women at all. And the same thing goes with retinoids. So topical and oral retinoids is contraindicated in pregnancy and breastfeeding. So oral isotretinoin, as we said, is derived from vitamin A, and it's an anti-inflammatory agent. It also decreases the sebum release, and it's thought to lead to a reduction in bacteria in the skin. It's only used over the age of 12 for 16 to 24 weeks. And the contraindication is pregnancy and breastfeeding. So basically all women who are taking the course of isotretinoin need to be on the pregnancy prevention program. So before starting isotretinoin, they need to be at least on one or preferably two forms of contraception for at least a month before starting treatment. So that could be combined contraceptive pills. And then what will happen is that the patient will go into the clinic and they'll have to take a pregnancy test. If negative, then they'll be prescribed for the first time for the medication. And then each month they'll have to keep going back to the clinic, take a pregnancy test, and then the final pregnancy test will be 5 weeks after finishing treatment. Now, there needs to be careful follow-up and monitoring just because of the severe side effects of the drug. So some of the side effects seen is dry skin and lips, photosensitivity, depression, anxiety, aggression, suicidal thoughts, and a rare side effect, but it can happen, is Stevens-Johnson syndrome. So moving on to erythroderma, it's an intense, widespread reddening of the skin due to an inflammatory disease. It's quite rare and it occurs 3 times more common in males, and it affects normally 90% of the body skin surface area. And over here is a mnemonic to remember the causes of erythroderma, which is ID scalp. So I, idiopathic, and it normally accounts for 30% of cases. D are drug reactions, and then seborrheic, contact, or atopic dermatitis can also be the cause. Leukemia or lymphoma, as well as psoriasis and pityriasis rubra pilaris. And here are just some of the examples of the drug reactions that can occur, such as gold, sulfonylureas, captoprils, penicillin, and carbamazepine. So the clinical features is that it can cause scaling 2 to 6 days after, and it can be seen as fine flake or large sheets. The palms can be the palms can develop keratoderma, and it can be given as a yellowish appearance. The skin can be quite warm to touch. It can cause itching, which can lead to lichenification. It can also be eyelid swelling, and you can see scaling on the scalp. So this can vary to hair loss to complete baldness. The nails can become thickened, and the patient may just feel unwell with swollen lymph nodes and malaise. So the diagnosis is that you can do clinical diagnosis as well as blood tests. So you would do a full blood count. So you'd see that, so the full blood count will show that it will be anemia, increased eosinophils, and increased white cell count. You can also do a peripheral blood smear. So if there's more than 20% of Sézary cells, this shows that it can be Sézary syndrome. So this is a form of cutaneous T-cell lymphoma, which can cause erythroderma. Things to also check is the CRP levels, hyperalbuminemia, and liver function tests, just to see if there's any complications, as well as electrolyte. You should also check for electrolyte abnormalities. You can also see the polyclonal gamma globulins and raised IgE levels, as that's quite typical for idiopathic erythroderma. Another investigation you can do is skin biopsies. So on histopathological features, you'll just on specific inflammation, or you can do direct immunofluorescence testing. So that if you think that the patient has autoimmune blistering or connective tissue disease. The treatment. So because it's serious and life-threatening, you'd have to hospitalize the patient, discontinue all of their medications, and monitor the fluid balance and body temperature. And you'd have to maintain the skin moisture. So you can do this by using wet dressings, emollients, and topical steroids. Other medical management is prescribing antibiotics for any bacterial infections or antihistamines for the itch. And the main thing is that you can, if you know the cause, then treat the underlying cause. So for instance, if it's psoriasis, then you can use methotrexate. If atopic dermatitis, you can use topical or systemic steroids. And the prognosis of erythroderma depends on the underlying disease process. So if you know the underlying cause can be corrected or removed, then the prognosis is generally quite good. However, for the course of idiopathic erythroderma is quite predictable. So it can persist for long times with periods of acute exacerbation. So that's basically it for the 3 conditions. And we have 3 SVAs just to finish off. So a 20-year-old who is in the second trimester of her first pregnancy comes for a review. Unfortunately, her long-standing acne has flared again, and she's keen to try something to improve the situation. Which of the following should be avoided? Wait for another maybe 10 seconds. Yeah, the majority of you guys have got it right. So it's topical isotretinoin. So as we said before, retinoids are contraindicated in pregnant women, regardless if they're topical or oral. So for this patient, erythromycin would be safe to give. The next one is a 35-year-old male is reviewed in the clinic for his long-standing skin condition, as you can see in the picture on the right. A month ago, the patient was started on potent topical corticosteroids to apply to the affected skin areas once daily. The patient reports good compliance, however, he has seen no improvement in his skin condition. According to NICE recommendations, which medication should have been started alongside the corticosteroid as first-line treatment? Give it maybe a few more seconds. Yeah, the majority of you guys have got it right. It's C, vitamin D analog. So as we said before, for first line, it is normally vitamin D analogues and corticosteroids to be used separately once daily for 4 weeks. Okay, next, the last one is a 15-year-old male returns to the dermatology clinic for a review. He has a past history of acne and is currently treated with oral lamicycline. There's been no response to treatment, and the examination reveals evidence of scarring on his face. What is the most suitable treatment? Okay, maybe 10 more seconds. Okay, I think we're divided on this question, but the answer is C. And the reason why it's because the fact that he has scarring on his face, which shows that it's severe acne, he's used oral antibiotics and they still haven't worked. So that would lead to signs of secondary care management. And within secondary care, you normally do give oral isotretinoin as for the cases that just hasn't been effective with other treatment.